Interested in learning more details about the motion appliance? Want to know how Dr. Carriere feels about whether it's skeletal or dentoalveolar? Want to know how to get cooperation with patients that aren't wearing elastics? Stay tuned. Our Golden Age of Orthodontics podcast sponsors make it possible for us to bring you new episodes. Lightforce Orthodontics is revolutionizing orthodontic care with cutting-edge custom bracket technology that offers personalized digital treatment plans that are fast, precise, and uniquely tailored to your patient's needs. Take advantage of the new standard of care with 3D printed, fully customized brackets combined with indirect bonding and digital planning. You can learn a lot more and take advantage of some special offers by visiting our partner page at pplpractice.com.
The future of orthodontics is evolving and changing every day. But although the way to achieve practice growth has changed, there's never been a better time to be an orthodontist. Let's get into the minds of industry leaders, forward-thinking orthodontists, and technology insiders to learn how they see the future of the orthodontic specialty. How will digital orthodontics, artificial intelligence, clear aligner therapy, remote monitoring, in-house printing, and other innovations change the way you practice? Join your hosts, Dr. Leon Klempner and Amy Epstein, each month as they bring you insights, tips, and guest interviews focused on helping you capitalize on the opportunities for practice growth. And now, welcome to the Golden Age of Orthodontics with the co-founders of People and Practice, Dr. Leon Klempner and Amy Epstein.
Welcome to the Golden Age of Orthodontics. I'm Leon Klempner, retired board-certified orthodontist, director of orthodontics at Mount Sinai Hospital, part-time faculty at Harvard, and of course, the CEO of People in Practice. And as usual, I'm joined by my partner and my daughter, Amy Epstein.
Hello. Good to see everyone. Happy to be here. I'm Amy Epstein. I have 20 years of marketing and public relations experience working with large brands in brand development, logo development, brand identity development, public relations, and then bringing all that in partnership with my dad to orthodontists so that they can better position them in the markets that themselves in the markets that they serve to be able to articulate what makes them different from other practitioners in their area, why patients should come to see them. That's what really we do at People in Practice. So I'm thrilled to be here today to share some of that with you and also talk a little bit about our guest today. We're thrilled to have Dr. Louis Carriere, who, if you don't know him, I don't know if there are a lot of people who don't know him, but he obtained his dental degree from the University of Complutense in Madrid in 1991. He then attended the University of Barcelona, where he completed his orthodontic training and received his Master of Science in Orthodontics in 1994, and then his doctorate in orthodontics, cum laude, from the University of Barcelona. Dr. Carriere was the winner of the Joseph E. Johnson Award in 1995 and the International Design Award Delta Gold for the Carriere Distalizer, which I think many of our listeners have used. He's a member of the Editorial Review Board for the AJODO and a contributing editor to the JCO. Before I talk about him, there's some more about Dr. Carriere. We mentioned him, my dad and me, a little bit in conversation because I was expressing that my daughter, who's your granddaughter, Dad, has, talking about concerns with seeing the orthodontist for the first time and perhaps needing to have braces or, early treatment because she's almost got all her adult teeth in. And this actually yesterday, she was talking to me, does it hurt? Does it this? Does it that? And, most of the time I say, talk to Grandpa and he'll have a look and tell you when it's time or whether it's going to hurt. But, what part of what we'll talk about with Dr. Carriere today, I think is, how to communicate to parents and patients themselves when they're children about how they can participate in their own orthodontic journey and how that changes compliance and changes anxiety levels and all of that. So Dad, she's going to be peppering you with some questions the next time you're here. I'm just warning you.
I get it. And her name is Maya, and she's a handful. Clinically, I used a lot of motion appliances in my career successfully, and I think she'd be a good candidate. My reservation about her would be one that's similar that I spoke with Luis earlier about reaching out to some of the Facebook groups before getting on this podcast to get some input from the community in terms of any concerns or anything they'd like me to talk about. And one of the topics had to do with cooperation. And, while Maya we would expect her to be compliant, a lot of kids sometimes are not. And that is an issue with the motion appliance, because if they don't wear the rubber bands, nothing happens. So my first question, clinical question, would be, Luis, so what do you do when you are dealing with a patient that is just not fully compliant with the elastics?
Well, first of all, Leon, Amy, it's a pleasure. It's an absolute pleasure to be in your podcast. I have been following you many years. You are doing a great interviews with podcast. So I have been very much entertained and learning a lot on many interviews that you have done in the past, and waiting also for the new ones to come, as the pearl of enjoying the moment when they come out. So thank you for all this work. Thank you very much. Now, I know that you are facing a big issue because you are going to be bombarded by many questions about your grandson. And this is very important that we give a good solution for your grandson and for your son. Amy? And class 2 malocclusion is a patient that your son or daughter is right.
Exactly, Maya.
Daughter, Maya. Sorry about that.
No, that's
your daughter is that is class 2. Normally, when I talk with them, and I go one after the other, and then I will focus on the cooperation. But first, talking about a little bit what we talk about, the orthodontist with the kids. First thing, that orthodontic treatment is the first responsibility that they are going to have as an adult person in their life. It's the first time where they are declassified from a baby or from a kid into a small gentleman or a small lady, in which we believe that they will do the best job because it's the new responsibility of the world of the adult people. So they understand and they want to be a part of it. This is very important. And secondly, I like to talk about the importance. And if you want, we can later brainstorm a little bit deeper on that. But I brainstorm about the importance of the orthodontics in life. Why? Because I always tell them, you are a kid, you are a baby, you are a girl, you are a boy, and you look very fancy with your tooth coming out here in front, and it's fun, and you look so cute and very nice. But when you pierce mustache, or when your face is becoming of a lady instead of a kid, then this is going to be, instead of cute, is going to be comic. And then it's not a problem. It's a problem. So you don't want to arrive there with this scenario. So we need to solve that. And the best moment to solve it is now, in this moment of life, that everything will be much easier, but we need something. We will give you a treatment that will be very small, very simple, very minimalistic, but has only one element that needs cooperation. Like a car that is a beautiful car, needs gasoline to be working, this is an orthodontic appliance that needs its gasoline to work, which means that it's the elastics. And here is where it comes, this responsibility of being adult enough to be a part of the declassified as a baby and reclassified as a junior senior. So, or junior adult, whatever. Then they like to be involved. Secondly, orthodontics is a profession that in the past was something that where the patient was absorbing the information of the orthodontist, and the patient was not supposed to ask many questions. But today, we change. The patients are used to answers in their telephones, answers in their everywhere. So they need to have information. So I think the era of having patients just accepting the prescription of the orthodontist without having any kind of comment or question or too many questions is not correct. Now we need to explain properly what we need, which is the treatment action, what is what we expect to accomplish, the timings in which we pretend to accomplish, and the targets and steps to follow to the end. So once we explain everything properly to a young kid, it's super easy to have their cooperation. And what is very difficult to have cooperation is when we just say, put the elastics. Okay, an order. Non-explanations behind. You put the elastics. Then don't expect anything from your patients because they don't understand what is your target. They don't understand which will be their effect. They don't understand how long it's going to take. They don't understand which will be the benefit for them. They don't understand anything. So, they will never comply with you. So I think that argumentation, that good communication with the patient, the parents are spectators of the conversation, but the one is the patient. So again, instead of talking with the parents, we have to focus on the patient as a small adult that we are giving them hey, here is the trophy of the being for the first time in your life and a small adult.
Yeah, it makes a whole lot of sense. And, and I understand the frustration that many of my colleagues have about treating with appliances that require a cooperation because it depending on, the communication styles and the skill sets of the orthodontist, they may not have, as compassionate a communication approach as you do, Luis, for example. But, in my experience, it doesn't have to be the orthodontist that does the explanation. If you have somebody in the office that's a good communicator, that is warm and playful sometimes and could relate to children, then that oftentimes is a good way to get the cooperation rather than trying to be something that you're not with a 10-year-old. Have somebody else just prescribe it and then pass it along. So that's worked well for me. And I'm a pretty good communicator, but there were some kids I just wasn't getting through to, but somebody on my staff was able to get through. I've also found, and I'm curious of your opinion, Luis, is that the younger patients are much more compliant than the older patients. The young ones tend to want to please, So for Maya, for example, I think she'll want to make the orthodontist happy. I think that, in her instance and in other kids, typically, I did a lot of early treatment in my practice. Those kids typically, want to go on the ride with you if you make it playful and make sure it doesn't hurt, obviously. they'll go with you. So I appreciate the insight. But let me just follow it up with another clinical question, because I can hear the rumbling in the orthodontic Facebook groups. So what do you do when you can't get cooperation? I mean, there's got to be some that it just isn't going to go. What's your go-to appliance, or what do you do next?
Yeah, normally I am very persuasive. What this means that I might take more time, but they end up cooperating. I have had patients over 1 year with emotion without cooperation. And then suddenly they click and they kill it in 3 months. So it's a matter of explaining. And I tell you that probably I had few failures on the cooperation, but those failures, all of them, that I can count probably in less than one hand, are sons of friends that they didn't pay for the treatment. That this is another subject that is very interesting because they don't take you in serious and this and that. So I removed the appliance and I said, hey, we will take in another moment when you are ready. We are going to treat you in the future. Okay? So this has been the story of this appliance. At the end, it's an appliance that has been simplifying so much the treatment, and I look forward having long-term stability results. But I never will go, for instance, for extractions in cases that I wanted to solve them. Without the need of removing two upper bicuspids. And then I ended up removing two upper bicuspids, because then what you do is to reduce volumetrically the 3 dimensions, the maxilla, and this is affecting negatively on the final profile of the patient. So this I prefer to stop and go back.
Okay, understood.
It sounds like you have, you take a particularly communicative approach at your practice, right? And not everybody does that. And you practice in outside or in Barcelona, right? And so, are there ways that you leverage your communication style and the partnership that you have with patients and the efficacy that you have with patients because of your communication in order to attract other families to the practice?
You know, Amy, one of the things that I have done many videos and animations of the treatments from the beginning to the end, step by step, and they are super useful to show them to the patient, to show them to the parents, for both, for the first appointment and after. Also, I send them by airdrop or by any other way by WhatsApp or whatever what they use. I send them to their phones in order to they have the treatment protocol and explain very clearly the steps that we are going to follow. And this is very important. I have seen that talking and explaining save a lot of time to the orthodontist. Instead of, we might think, I cannot lose my time because I'm super busy. I cannot talk that much. Well, this is make you spend lots of hours of chair time that if you have been just talking for 10 minutes in advance, explaining your intentions, explaining your protocol, spending all the steps you want to follow, everything would have been so much easier. No? And this has been my experience at this point.
Yeah. The educational tools that to the patient and the parents and the practice, I think that's those are underutilized tools, communication tools by orthodontists. We often will see that there are proactive communication tools. We'll often see, this sort of education when there's a more acute change, let's say, happening in the practice. There's a doctor coming in and we want to communicate to everybody about this new associate, or doctor is retiring or opening up a new office, these sort of transitional, but it's all about communication and education when it comes down to it. And even when we help our practices advertise to communities to bring in more patients, it's all about education and communication, because when you explain things, that's when people understand it. They have fewer questions. They're made more comfortable. They can see you as someone who is an authority on what you're talking about, and all of that lends credibility and authenticity to your practice and makes people want to come to see you.
Absolutely. Amy, you're coming from the marketing world. And communication is all about sending the message. Do you imagine sending a message without communication?
Yep, not possible. So it seems like we're very aligned in the approach that in the way that you engage your patients, and that's probably why you have so much compliance.
Well, it's trying to make my life easier and brainstorm what I would like as a patient, and that's it.
So Luis, I am interested in your views of aligners and some of the appliances that you're using in your own practice in conjunction with the motion appliance. But I want to just circle back into another issue that I see coming up from colleagues of mine, which is discussion regarding the mechanism of how the motion appliance actually works. So, my understanding is that, there's the rotation of the molars, there's a distal force, there's a meso component with class 2 elastics. But, there are a lot of colleagues that are questioning whether the position of Henry Schein as they're promoting this has to do with whether we're dealing with a skeletal problem, or are we treating a skeletal problem, or is the correction primarily dentoalveolar? So I wonder if you could just clear it up for the audience, because I know that it comes up, and I haven't really seen a lot of advertising that promotes skeletal changes with the motion appliance, but maybe you have a different view.
Yes, thank you. This is a very nice question, very good question, and how the motion works, okay? The motion appliance is an appliance that intends to generate and move groups of teeth from canines, premolars, and molars from class 2 into class 1, and from class 3 into class 1, converting at the beginning of the treatment the class 2 into a class 1 or the class 3 into a class 1. From in the posterior segments of canines, premolars, and molars. Okay? So, by the motion appliance, when I conceptualized the motion appliance, I was very much deeply studying long-term stability, and which was the key for having a good occlusion of molars for the years to come, and having the canines and premolar occlusion for many years in class 1. And the important thing was that rotation to the distal of the molars was one of the most important things. By Arnold Stoller did a beautiful article in 1956 at the American Journal of Orthodontics, in which he explained very well that rotation of the molars and uprighting of the molars was necessary to accomplish adequate occlusion of our teeth for the long-term stability. Okay? So what I did is to go to the mother nature and imitate what mother nature had created. What I did is to imitate the coxofemoral joint. The coxofemoral joint that was with this ball and socket to rotate and upright. I needed to upright because molars, Henry did a beautiful article studying thousands of malocclusions, and he saw in 1954 in the American Journal of Orthodontics, and he saw that the 83% of our malocclusions, they have excessively medially inclined molars, and medially rotated molars. So what we needed is to upright those molars and rotate them. So I did this head ball on the joint of the motion appliance and flattened the poles and gave also tolerance to be bonded on these medially inclined molars that the 83% of our malocclusions are suffering. Because if you end up in a malocclusion with your medially inclined molar, this medial inclination is pushing towards class 2, all the premolars and canines, and you're losing your occlusion easily in a short run. So uprighting is super important. This is why I did the motion appliance site specific. Okay? So biomechanically speaking is that motion appliance is to rotate the molars, upright the molars, move the posterior segments as a block to accomplish class 1 at the beginning of the treatment, in class 2 and in class 3. And this appliance is helping into accomplishing a solid and consistent occlusion. And what is the motion appliance with the characteristic? Is site-specific, means there is a left and there is a right one. So by knowing this, is today there are some imitations, some copies of the motion, but they are universal. Why is universal? Why they did it universal? Because they don't know what is the thinking behind of biomechanics when I conceptualize the motion. And they just simplified by copying without knowing what was the biomechanicals behind. Probably engineers. Now, what is this about? Is this an appliance that is functional? This is an appliance that is skeletal? Is a dental alveolar? Well, this appliance is an appliance that normally the major amount of our malocclusions of class 2, for instance, when we talk about class 2 and class 3 as well, but if we talk about class 2, for instance, the major amount of our malocclusions, they have an incorrect positioning of the disc. The disc is shifted forward. There is a beautiful article of a Swedish group that they studied MRIs of class 2s and class 3s, and they showed that the discs were shifted forward and the condyle was back and up. So the motion appliance is changing the occlusal plane. By changing the occlusal plane helps into the distraction of the condyle from the deepest part of the fossa. And this distraction, this dislocation of this condyle from the deepest part of the fossa helps into a spontaneous reposition of the disc and a spontaneous reposition of the mandible forward. Okay? This is not a matter of growth, because if you look from the beginning to the end, the short treatment of the motion appliance is normally, the average of treatment is around 3 months, 4 months maximum. If the patient cooperates. If you have issues of cooperation, then can be elongated. Okay? So when you start with a retruded mandible, you accomplish a adequate position of the mandible, but this is not going to be growth. It's going to be a reestablishment of the function and the relation in between the maxilla and the mandible. And amazingly, this is going to be super stable, because today one of my courses is all about long-term stability. And when I say long-term stability, means 16-year follow-up of the malocclusions with retruded mandibles, with adequate position of the mandible at the end, and how it has been kept along 16 years. So this is the effect of this appliance. Now, there is a lot of evidence based on the use of the motion appliance. And before you were telling me about, I am pointing out a little bit on the different questions that you have been placing, because going back and forth. But you were saying, well, some of my colleagues are concerned about this appliance, if this is going to be cooperation. Well, this appliance is an appliance that is the fastest appliance to accomplish the correction of the malocclusion. And there is something in common of the overall already hundreds of articles published on the motion appliance today. There is a big evidence based behind, published in the American Journal, published in the Engel Journal, Engel Orthodontist, at the JCO, and several other journals that has been published today. And all of them, they say that this is an efficient appliance to accomplish the treatment in class 2, and this is an efficient appliance to accomplish the treatment in class 3. So this is the important thing, that this is an appliance that if the patient cooperates, you can strongly promise the results to your patient.
So just to wrap it up and just to be clear, we're other than some possible repositioning of the mandible if it's retruded, other than that, we're primarily talking about dentoalveolar changes, the teeth moving through the bone in segments. We're not growing a mandible. We're not preventing growth in a class 3. We're primarily doing dentoalveolar movements. Is that a fair assumption?
Yes. What we are doing is we are changing the occlusal plane. This is making the distraction of the condyle. This is releasing the space for the disc. This is repositioning the mandible forward. This is locking everything in class 1 in this new anterior-posterior relation of the mandible forward in relation to the maxilla, and then the growth that is going to come in the adequate direction. We'll redirect the growth into the direction of this new stable scenario, sagittal and anterior position of the mandible, sagittal correction that is stable, and the growth is going to go into this direction. Okay? So this is what we are talking. When we are seeing articles about mandible growth of herbs, appliances, or the growth is about millimeter and a half, 2 millimeters. 2 millimeters, they don't make the difference in a mandible position. They don't make the difference. You cannot see 2 millimeters change in a mandible position. If there is a change on the relation between the maxilla, functional change, reposition of the condyle, then you will see the change beautifully in the mandible. If there is a change of the occlusal plane, this changes the width appraisal. There is a massive change of the aspect of the patient. This is why we are giving an absolute nice alternative to surgery in class 3 cases. And this is something that I would like to brainstorm a little bit if we have time.
Well, we'll definitely have to schedule another podcast. Time goes by so quickly. But Amy, I know you had something that you wanted to bring up.
I do. I'm wondering, we're talking a lot of shop talk, as my dad says. And I wanted to know if we could shift gears and look ahead a little bit. And, in partnership with Henry Schein Orthodontics, what are you working on? What innovations are in the hopper, and what can we look to expect? We have the AAO coming up again in late April, I think, this year. We'll be giving some talks there, and I'm sure you are always doing. You lecture around the world. I'm sure you're going to be giving a talk there too. Tell us a little bit about what we can look to expect.
Yeah, well, now I think I am in a moment in which I am a little bit more creative. There are moments in life, no, and now I'm working a lot on how to diminish the number of appointments, what we call minimal touch orthodontics. And what we want is to make life easy for our patients. And this you need an appliance for, like the motion, for instance, that helps you, and you position it and you remove it when everything settles in class 1. This means that you only need 2 appointments: the positioning and the removing. In between, you can monitorize in the distance. For instance, using the green technology or dental monitoring or whatever you use. No. Second, then once you have the class 1 of the posterior segments, you want to go into the next stage, that is the brackets. Well, we have the Carriere SLX bracket that is a passive, ultra efficient in terms of rotation, because it's a full size slot covering with the sliding door, and with the 3-wire sequence. And this is giving us the possibility of diminishing the number of appointments because we squeeze the capacity of the wires to accomplish. In fact, on those cases of short treatment timing that I'm now focused, I try to go to the 2-wire sequence instead of 3-wire sequence. Okay? Our wire sequence is 3, but now I'm trying to go into the 2-wire sequence in order to diminish the number of appointments. Now, was ruining all the project of the minimum touch orthodontics. What was that? The elastic chain. The elastic chain that we place elastics to close certain spaces in between the incisors, and then suddenly you place the elastic chain, and this chain is losing power and it gets dead, and then you need to change it. Means several appointments to change an elastic chain because it's not closing as you expect because it's suffering what it's called creeping, degeneration of the properties because there is pressure, moisture, and temperature. So I said, hey, we need to figure out something. So I came up with an idea of using memory of shape. So we have night eye. We are lucky to have night eye. So I designed an infinity loop, that this loop was intended to substitute the elasticity of the chain, supposed elasticity because it suffers creeping. And instead of that, we were placing the infinity loop. This infinity loop has a memory of shape and closes the spaces in one step. Now this means that it's completely eliminating the number of appointments in between. And amazingly, as it has memory of shape, the appliance, once has the gaps or the spaces closed, gets totally passive because has the original form. It's not stretched. So it's very interesting, and now this is called the Carriere infinity loops. The next is that it's a night eye ligature, which is also memory of shape, in order to convert every traditional ligating bracket into a low friction bracket by the use of the night eye ligatures, substituting the elastic rings by night eye ligatures. This is the next project. And then I have also that an appliance that this year I am coming with this innovation, but it was not going to be yet in the market, but I will be talking about that. This is a premiere that is going to be a TAD, temporary anchorage device. But how? With an active abutment. And the abutment will be of night eye. So now the one doing the job of traction will be the active abutment of the temporary anchorage device. Instead of having the anchorage device as a passive receiver of an elastic chain that is going to be super inefficient, now we can just bend, reposition the tip of this temporary anchorage device, and this will move everything with the memory of shape again.
Well, we look forward to seeing and learning more about that when we see you in April at the AAO. Thank you for talking about that with us, and thanks for taking the time to talk with us today. We know you have a lot on your plate. You lecture globally and teach classes, and so we appreciate the time that you've spent with us today. If our listeners would like to learn more or ask you a question or have a follow-up, how might they be able to reach you?
Well, there is a lot of information at carrieresystem.com. Carrieresystem.com. And this is very much information. And also in my website, at carriere.es, you have more information. So basically, around this. And also there is, I tell you, osteocom. There is that they did a nice record of a course I did that I am very, very happy of it. That they did, and it's beautiful. It's 6 hours course, and it's very interesting if someone wants to look at it.
Okay. That's very helpful. We'll go ahead and we'll share that link when we post this podcast live.
Amy.
Thank you again for joining us today. And we'd love to have you back, and we look forward to seeing you soon.
It's
Thanks,
a pleasure.
Luis.
It's a pleasure, an honor, and looking forward your next podcasts that I'm thirsty of them.
We're glad to hear it. And, for you and for all of our listeners that enjoy this episode and are also looking forward to other episodes, you can download them or subscribe to the Golden Age of Orthodontics on Apple Podcasts, on Spotify, SoundCloud, YouTube, or wherever you get your podcasts. And if you enjoyed it, we appreciate that. Everyone should share it with a colleague. For more information about People in Practice, which is the marketing consultancy that my dad and I co-founded about 15 years ago, you can sign up you can look at our website and learn more about the business and contact us there. And there's this little chat at the bottom. If you type in say a little message or whatever, it actually goes right over to my dad's cell phone, and he'll write back to you there. He'll text you right back. So thanks everyone for watching and listening.
So someday I want to be as smooth as Luis in terms of
You have
communication. I mean, I don't know how. I don't know how you get any sleep. Do you sleep at all, Luis?
I tell you something. I am very bad sleeper. This is one of my issues. I have long nights, very long nights.
All right. Well, that's probably where the innovation and ingenuity comes into play. So I want to thank everybody for watching and listening. Of course, you can contact me with any questions that you may have. My email address is leon@pplpractice. You can direct message me on Facebook, on LinkedIn. I'm all over the place. So remember that for forward-thinking orthodontists, it really has never been a better time to be an orthodontist. So we are in the golden age, and we'd like you to take advantage of it. So until next time, see ya.
Thank you for tuning in to the Golden Age of Orthodontics. Subscribe now on Apple Podcasts, Spotify, or visit our website at thegoldenageoforthodontics.com for direct links to both the audio and video versions of this episode.